that, I'll hand it over to John.
Okay, thanks, Habib, and thanks for all the organizers for inviting me to speak. So yeah, Habib gave the title here, what I'm going to talk about. I'm interested in cognitive aging, and in this particular talk, talking about the role of social isolation and physical activity. So I'd like to start with some acknowledgments, and first and foremost is the one to my co-authors and to the first author on this, Shauna Hopper, who we heard from earlier. We started meeting about this over coffee about a year ago, maybe in the fall of last year. We were working off of a grant I'd written, and I left it vague enough that we could go in a lot of different directions with it. And so we had some fits and starts, but we kind of, over time, settled on a plan, and I'm happy that this aligns with us reaching the completion and having just finished a full a draft of the manuscript here. So I'll start. I think I saw this exact same graph in Loon Lee's presentation earlier. So this is probably not a surprise that as a population we're aging. So this is showing the proportion of the Canadian population over the age of 65, and as you can see, it's steadily increasing in proportion. Of course, this is not a bad thing at all. This is, people are living longer and healthier lives. Though there are some potential downsides here. What I'm showing you here on this other graph is the association of age with dementia risk, and this would encompass all forms of dementia. And basically what this is showing is that with increasing age, the risk of dementia of one form or another increases, and it kind of picks up once you reach into the 80s here. And so you put these two things together, and you have pictures like this, which is showing that the prevalence and incidence of dementia are projected to increase here in Canada and many other countries over the near-term future. And so with this in mind, I've been interested in a field of study called health neuroscience. And this is a very much a simplified diagram of what this field is interested in. But in essence, it's interested in the interconnections between physical health and health behaviors in individuals and the cognitive and brain health of those same individuals. And so this field of study can help us think about, theorize about, test intervention or prevention strategies so that we can reduce the burden of dementia in the society. One thing I'll point out quickly here is you can see the arrow here is bidirectional. So a lot of times the field focuses on how health behavior might impact cognition, but the opposite can be true too. So as our cognition changes with age and potentially through impairment, that can also have an impact in the kinds of health behaviors we engage in. I'm not really going to talk about that part, but it's an important feature of this field. And so I've been working in this field for the last decade plus, and through most of that time I focused on the individual. But it became quite clear that we're not working with individuals in isolation from their environment, and that this field of study and the research that we do within it could greatly be enriched by considering environmental factors. So that's an amorphous term that would include a lot of things, aspects of the built environment, as well as the social environment. And so one of those things that I'll focus on here today is, I guess in line with the social environment, is this concept of social isolation. You've heard many previous talks today about social isolation here, and various ways to operationalize it. For this study, we're using an approach first proposed by Andrew Wister in a paper from 2019 using data from the Canadian Longitudinal Study on Aging. And you can see there's kind of 3 components that make up social isolation. This functional subjective is really in line with the subjective feeling of loneliness. And then we have a structural objective component. So this entails the numbers and the types of connections one has with family members, friends, people in the community. And then the functional objective would be more aligned with the social support, the degree to which those members provide social support of various things. This concept of social isolation and loneliness have been connected to a myriad of health outcomes. Relevant to this talk is the association with increased cognitive impairment and increased dementia, as well as a connection between social isolation and reduced physical activity and greater sedentary time. And so kind of linking all these things together, we, primarily Shauna and I, became interested in this question, which is, might physical activity provide a link between social isolation and cognitive aging? And to evaluate this question, we turned to the Canadian Longitudinal Study on Aging, and in particular the first 2 waves of data collection here. And so that allowed us to look not purely in a cross-sectional fashion, but allow us to look at cognitive changes over a short period of time. So we could look at social isolation and physical activity at baseline and see, does it connect with changes in cognition over the first couple of waves of the data. So for our measures, we use the social isolation index, which I briefly described previously. For physical activity, we used a self-report measure created for older populations. And then with respect to cognition, we focused in on 2 domains here, one being executive function and the other being memory. So these are 2 of the kind of most important aspects of cognition. And importantly, these are 2 domains of cognition that change across the lifespan and typically show age-related decline. Unfortunately, starting earlier than we often care to notice, which is starting even in midlife, we start to see subtle decline in both memory and executive function. And so I'm going to show 4 kind of sets of findings here, and these all work together to address this question about whether physical activity might link social isolation to cognitive decline. And we kind of need all 4 of these things to work together to provide evidence for this. So the first part of this is there a connection between social isolation and physical activity, or put otherwise, physical inactivity? The kind of a heuristic you can follow in kind of interpreting these results is that you might be able to see a dashed line here. As the dots move further away from that line, in this case to the left, the stronger the effects. In subsequent slides, it'll be in the other direction, but the farther away, the stronger the association there. And in these analyses, we stratified our group. So the CLSA has a quite large age range, so 45 to 85. And then we have males and females. And so we stratified both by biological sex and by age, using kind of the heuristic of middle age, 45 to 65, and then 65 plus. And the reason we did this was to kind of entertain the possibility, to allow for the possibility that these associations might be different for men versus women. They might also be different depending on if you're middle-aged or older-aged. There's a number of reasons to do this, one of which is that physical activity tends to be higher among middle-aged adults compared to older adults, also higher, at least in terms of self-report, in men versus women. And then social isolation tends to be higher in the older group versus the middle-aged group. Okay, so with respect to this initial association, social isolation with physical inactivity. So regardless of the group, we see that there is an association. So the greater the social isolation, the less likely one reports activity, or the lower amount of activity reported. What's interesting here, shown in the green and the gold, is that this coupling is stronger amongst our men compared to our women, regardless of the age group. So both of our middle-aged and older-aged males, we have a stronger association there. Now, the next kind of piece of this puzzle, the association between physical activity and cognitive changes. And so again, we have kind of two aspects of cognition we're interested in, so that's why this thing is paneled as it is. And what we see is, for both our executive function change and our memory change, we see a stronger connection in our older two groups compared to our middle-aged groups. So stronger association between physical activity and cognitive changes in the older two groups. And then the next piece is the association between social isolation directly to cognitive changes here. And here we see something kind of similar to that previous slide, where the connection between social isolation and cognition is stronger for the two older groups compared to the two middle-aged groups. And in particular, it seems to be stronger for our aspect of cognition memory as compared to the executive functioning. And then finally, we put all of these three puzzle pieces together and evaluate them together. And what we see is that connection going through physical activity is particularly strong for our two older groups, and especially for memory. So this question of whether physical activity might mediate the association between social isolation and cognitive changes seems to be most evident in our two older groups, and above and beyond that, it seems to be most evident for changes in memory. We also, I should note, we also see it with respect to executive function change, but only for the older males, and that's the kind of the green dot in the left panel. So, before kind of coming to some conclusions, it's good to acknowledge any limitations to the data here. I won't repeat this kind of statistical jargon, but we'll say we're using observational data here from the CLSA, and there's of course lots of strengths to that. It's a huge data set allowing us to detect small effects. It's representative of the population, which is wonderful. But there's always the issue of, if I were to intervene upon a population, would I get the effects that I've shown you here? Would the magnitude of the effects, would they replicate? And without directly doing that, it remains unclear, and that's because there might be some variables, some what we call confounders that we haven't controlled for. We've controlled for many of the suspected confounders, but there might be others. And so in a lot of ways, this is kind of provides a guidepost, and future studies might want to take this and evaluate an experiment or a trial that provides an intervention. Another limitation, and this is common, especially when you're doing studies in large samples, is that we're using a self-report measure of physical activity. And so People tend to be biased in terms of how much they report. There's social desirability, so they might report more physical activity, but I mean, the opposite can be true too. You might forget some of the physical activity you're doing. Or you may not consider, walking to the train stop being physical activity, but that certainly is. So it kind of works in both directions in terms of that fact. So those kind of limitations there. Some conclusions are that, so it does seem to be that there is a connection here, linking social isolation to physical activity to cognitive decline. And this especially seems to be true for our two older groups here as well, and in particular for memory functioning, and again for executive functioning in the older males as well. It's interesting, emphasizing this point I've noted before, which is that the connection between social isolation and physical activity seems to be strongest amongst the males as compared to the females. Why that might be, I guess I could only speculate. I mean, broadly speaking, social isolation or its inverse, having social connections, can promote physical activity in a number of ways. So it can provide some social accountability. So if you plan to go out for a walk with a friend, you're accountable to that friend to do that. Or, a lot of the social activities we do is inherently physically active, whether that be the most obvious being sports, or again, going out and going out to dinner, taking the train downtown, that sort of thing involves physical activity. And then, as I mentioned here in the context of the limitations, these results would suggest that that interventions could be created to evaluate these things, and in fact, they could include not only physical activity but a social enrichment component. There's been a little bit of research here. I've referenced one really small study in the last couple of years that created an intervention that involved not only physical activity but was group-based to encourage social interaction. And so that could be, of course, a promising avenue of research. And with that, thank you.
Hi, everyone. Thank you so much for the invitation to speak to you today. Today I'm going to be sharing some of the work that I'm doing as part of my postdoctoral fellowship. I'm cross-appointed here at the GRC, supervised by Dr. Andrew Wister, and I'm also at the BC Centre for Disease Control, where I'm supervised by Dr. Kate Smolina, who's the head of the BC Observatory for Population and Public Health. So my goal today is to share some overall big picture aims and directions that I'm taking this project in, but it's very much work that's currently underway. So today we'll sort of give you the conceptual underpinnings of the project and start a discussion around the work, but I hope perhaps I can come back in a year or two and present our findings. So this project is focused on multimorbidity, and the concept multimorbidity was already defined for us yesterday so nicely by Shuzhou. So in line with that definition, multimorbidity is simply when an individual has two or more long-term diseases. And I think it's helpful for us to start by conceptually delineating multimorbidity from a closely related concept, which is comorbidity. So in comorbidity, there is a single disease that's an index disease of interest, and you're studying the impact of additional diseases on that individuals with that one disease. Multimorbidity, on the other hand, is considering all diseases that an individual might have equally. So there's no single disease of interest. You're not restricting your study population based on the presence of any disease, and you're just looking at the intersections of all possible diseases within the individual. And when we're talking about long-term conditions in multimorbidity, we're typically talking about the major chronic diseases that are tracked usually at the population level. So here is a list of diseases that are included in the BC Chronic Disease Registry. And this disease list is very typical of the types of diseases that are included in work around multimorbidity. So one thing you can notice when you're looking at this list is many of these chronic diseases are diseases that classically show onset and highest prevalence in middle to older age. And so we know that age is a risk factor for many of our major chronic diseases. And another thing that you can notice by reading this list is that having one disease might increase your risk for other diseases on this same list. So for instance, we know that hypertension is a major risk factor for heart disease. So this means that if you have one disease, you might be more likely to have a second one. And so when we consider these two factors together, we know that the probability of developing multimorbidity will increase as you age. And that's why this is such an important concept when we're thinking about the health of older adults. And in line with this probability-based framework, we see this borne out in the data. So many older Canadians are managing multiple chronic diseases. This is data from Alison Feely's group using the Canadian Chronic Disease Surveillance System. And what this data is showing is relationships between age and the prevalence or percentage of each age group, along the bottom axis here, that have 2 or more chronic conditions. And what you'll also see here is this is data across Canada. So each of the lines here is representing data from a different province. And what I'd like to draw your attention to here is this 50% line. And so what we see is that in individuals around the age of 65 to 69 and up, more than half of Canadians are managing more than 2 chronic conditions. And so this really underscores the importance of multimorbidity within our older population. And when you have multiple chronic conditions, of course, it's almost too simplistic to say that this increases the complexity of your healthcare needs. So individuals who are managing multiple conditions, experiencing their healthcare as more fragmented, they might be coordinating multiple specialists, multiple different prescriptions, and they, as a result, have a higher treatment burden. Individuals with multimorbidity are more likely to be hospitalized, and when hospitalized, will likely have a longer stay in the hospital. And as individuals with multimorbidity age, they're at an increased risk of loss of functional independence. So again, all of these just tell us why it's so important that we start to monitor and track multimorbidity in our population. So it turns out, though, as I've learned in my postdoctoral work, that understanding multimorbidity is a very complicated question. And the reason for this is because there's so many diseases that are included in this concept, and they each have different and unique effects on health. And so I'm going to sum up the complexity problem here by saying chronic disease, it's not an addition problem. And by this I mean we know that diseases interact, and sometimes the cumulative impact of multiple diseases can be greater than the sum of their parts. So this is not a case of one disease plus one disease equals 2. An individual who has 2 chronic conditions can sometimes have an effect that's greater than you would expect based on the individual components. A classic example here would be diabetes and depression, where there's bidirectional risk factors involved, and health outcomes are worse than you would expect for individuals who are managing both conditions. But the thing is, especially at the public health level, the way that we track and monitor our diseases is often with a single disease focus, and treatment protocols can often have a single disease focus as well. Another way in which chronic disease is not an addition problem is that individuals who have the same number of diseases have very different health profiles. So we can consider 2 individuals, both have 2 chronic diseases. The first has diabetes and stroke. The second has osteoarthritis and depression. And of course, it's very evident when you think about this that these individuals have different risk profiles, they have different treatment needs, they might have very different experiences of their health. However, a lot of multimorbidity work would consider these 2 equivalent because they both have 2 diseases, and a lot of multimorbidity work starts by just counting the number of co-occurring diseases. So another way that the addition doesn't work is 2 does not necessarily equal 2. And so getting into all of this complexity, the broad goal of my postdoctoral work is to try to develop new tools that can account for this multiple disease lens and can start to unravel some of these intersecting effects of different specific kinds of diseases. And specifically, there's a big emphasis in my work on developing tools that can be translated toward population health surveillance of diseases. So I'm going to tell you a little bit more specific detail about each of these projects that I'm currently working on. The first I'm broadly titling Multimorbidity Surveillance in BC, and this is the work I'm doing embedded at the BC Centre for Disease Control. And we also have an excellent advisory group that I'm working with to partner with this research, including experts at the BC CDC, representatives at the Ministry of Health, and at PHSA. And this team is really making sure that the work that we develop is going to be useful and actionable for our provincial health systems users. This work is relying on administrative data sources, so we're looking very heavily into the BC Chronic Disease Registry, which I mentioned before. The BC Chronic Disease Registry, it has coverage of essentially the entire population of our provincial population of healthcare users, and it's looking at records from prescriptions, from MSP, and from hospitalization claims. But we're also working with experts at BC Cancer to try to integrate the BC Cancer Registry as well, because cancer is, of course, another very important chronic condition that's very prevalent and has a huge impact on health. So that work is underway. So in the first phase of our project, we're trying to estimate the overall impact of multimorbidity with some of our classic epidemiological measures with disease counts. Now, I mentioned the limitations of disease counts earlier, and the limitations are still true. However, counting the number of diseases can be a good way to roughly index the burden and severity or complexity of multimorbidity. So I'm going to share some very preliminary data with you today, where, again, we're looking at relationships between multimorbidity, disease counts, and age. So we have different age groups represented in each column. This data is all from 2019-2020. And the y-axis here is indicating the percent of people in each age group who have different numbers of chronic conditions. So individuals with one chronic condition are represented in gray bars here, and then all of the red bars are different levels of multimorbidity counts. And so there's a few things that stand out when you look at this figure. The first is that, consistent with the work that I presented earlier from Dr. Feely's group, the majority of older adults in BC in 2019 did meet the definition of multimorbidity. However, something else that really stands out to me is, first of all, that individuals in our 50 to 64 age band have at least one, more than half have at least one chronic condition, if the 2+ multimorbidity definition isn't quite met yet. And another thing I find quite striking in this is that for our very oldest adults, those who are 80 years and older, more than 25% of them have 5 or more chronic conditions, and this is without including cancer in these numbers. So this really speaks, again, to how common multimorbidity is and how much of a challenge it can be for our older population. The second phase of our project, this is where we're really starting to try to unravel our disease-specific relationships, and we're doing this with a network science approach. And so in network science, we can look at interrelationships between various factors. So here, we're using each disease within our registry as a node within the network, and we connect the nodes based on strength of association between diseases. And for us, we're measuring strength of association based on how likely it is that individuals have 2 diseases, how much more likely it is that individuals have 2 diseases based on what you would expect with the individual prevalence of those diseases if there were no connection between them. So, sorry, that was let me try to phrase that more simply. Essentially, how often are you seeing these 2 diseases together, and is it occurring more than you would expect based on random chance? So are the diseases connected in a non-random way across the population? So a network science approach is really nice because it gives us a visual representation of these patterns of association and disease. And so you can start to unpack various aspects of the network. So for instance, you could identify if there's any one single disease that's highly interconnected between different points along the network. And this might represent a sort of keystone disease that is a transition between multiple types of multimorbidity. And the other thing you can do, and this is sort of the key analysis and output of this research, is you can apply clustering algorithms to your network data to identify groups of diseases that are highly connected. And these are going to represent your common multimorbidity disease clusters or groups. And this is really useful because we can move from just thinking about the number of diseases people have to trying to delineate specific patterns of diseases that often co-occur. And if these patterns are co-occurring for non-random reasons, this might be because they have shared etiological or causal patterns in the actual physiology of disease, or it might be because they have shared environmental or behavioral risk factors. So these clusters could represent opportunities to develop policy and intervention for prevention or for management and streamlining of care for these disorders. So I kind of explained part of why network analysis can be useful, but there's other questions that we might unpack. Of course, we want to be able to identify our disease clusters. That's a central aim. You can also then, once you've identified the clusters, ask if these are different in different demographic groups, how they vary across geographic regions, or how they might be changing across time. And you can also ask questions that relate to temporal progression of diseases in the network. So how are individuals moving from different states, from a non-disease state to various cluster membership? The primary project output that we'll be working on for this phase is creating an interactive dashboard that's presenting all of this data in a form that individual users can come to and filter and ask their own questions. BCCDC, of course, has a long and really high-level history of creating interactive dashboards. I know I myself checked their COVID dashboard very regularly at the height of the pandemic. So this type of format for data presentation can be really useful. And it's useful because people can come and ask their own questions of the data. If you have a regional epidemiologist who wants to know about multimorbidity within their specific regional context, they can ask that question. If you have a specialist or a physician who wants to know about comorbidities within a disease of interest for them, they can answer those sorts of questions. And we can also have people who ask questions around age or around different times in our province. So the next project I'm going to talk about is a systematic review that I'm working on here at the GRC. And we also do have some of our BCCDC scientists on board with this project. And the goal of this analysis is to look at other studies that have tried to apply different disease clustering algorithms in multimorbidity and see how stable and predictable have disease clusters been in the literature to date. And for those of you in the audience here who are GRC scientists, I'm just going to put in a little plug that I'm going to be presenting at the GRC research meeting very soon with a lot more detail about the actual analyses here. So I'd love to see you there and have your feedback. So similar to the talk that we saw earlier from John Pickering, he introduced a systematic review methodology. The goal of our systematic review is to try to find all of the studies that have applied data-driven analytic approaches to identifying specific patterns of diseases in multimorbidity. And from this, we're going to extract from a list of diseases what are the specific clustering results that have been obtained in the previous literature. So perhaps network science is sort of my hammer, and I'm seeing a lot of nails around, but I actually think network analytics are very helpful in a lot of contexts, and this systematic review is no exception. So we're going to create a meta-analytic network where, again, the diseases are forming nodes in our networks. But here, instead, the strength of association is going to be measured by how frequently two different diseases have appeared in the same cluster in previous clustering research. And then once again, we can apply a clustering algorithm and create a meta-cluster of our diseases, and we can use additional data mining and stability metrics to see how replicable those clusters have been. So we might expect to see things like hypertension and diabetes and stroke co-occurring, and that might be a cluster that's been very stable in previous research. But there might be other disease clusters that maybe aren't as well known or well researched, but turn out to be quite reliable across a variety of studies. And those could represent new disease relationships for analysis and future work. So overall, our project is going to be, well, the two projects that I outlined will be generating foundational epidemiological data of multimorbidity within our province. We hope there's potential here to advance the ways that we do public health surveillance of chronic disease, and especially bringing in more of a multiple disease lens. And we're going to develop and disseminate knowledge on the specific composition of disease patterns in multimorbidity, both from our provincial analysis and also the systematic review and meta-analysis. And I think I'd really like to take a moment here to talk about the positioning of this project. So really, this project is coming from a more epidemiological and biomedical lens. That's my background. My background's also in neuroscience, actually. And our interest is improving how we're monitoring multimorbidity at the population level. But I think what I really have been getting out of my time here at the GRC, and what I've been so inspired by the many other presentations we've seen over these last 2 days, is it's important for us to acknowledge the limitations of this type of lens. So, I'm using administrative data. Administrative data is limited in what it can tell us, and it can't tell us about how people with multimorbidity are perceiving and experiencing their health and their illness, and it can't really tell us about the sociological and the personal context that's allowing people to navigate the challenge of multimorbidity. So here I've cited Dr. Wister's foundational work on the Multimorbidity Resilience Index that, of course, was so nicely explained by Shoju in your presentation yesterday. And I think this is a really important perspective for us to consider. But that being said, the reason that I'm very excited to be working on multimorbidity at the population level is because I think that multimorbidity naturally encourages taking a person-centered approach in understanding health and disease, because we're considering all of the multiple intersecting diseases that an individual is managing. So the individual becomes the most important unit of analysis. And because you're thinking about how diseases interact and how people need to navigate the healthcare system considering multiple diseases, this also naturally encourages questions around integrating our healthcare system and developing more streamlined approaches so that people can manage their illness burden rather than just managing each disease in isolation. So for these reasons, that's why I've really been enjoying working on this and have been really inspired by all the talks that I've heard from this week. So thank you all so much. And I want to acknowledge, of course, my supervisor, Andrew Wister, and Kate Smolina at the BCCDC, the many people who have been helping me complete this work, our Multimorbidity Advisory Group, who's been really foundational in shaping our population-level analyses, and the funding agencies, CIHR and Michael Smith, that have funded my postdoctoral fellowship, and also our data stewards over at the Ministry of Health. So thank you very much.
So just to give the context of the next presentation, the speaker is not here, but he's Dr. Mohammed Javad Nouri. So Mohammed is a postdoctoral fellow working with me. He's funded by the Alzheimer's Society of BC. And just to give the context, because he's not his standalone presentation, but it would be helpful, I think, to give his presentation, the context of his presentation, which is connected to what we talked about yesterday. If you were here yesterday morning, we talked about the Demscape project. So just to give the context of Mohammed's presentation, in the Demscape project, we engaged 32 individuals living with mild to moderate stages of dementia in the province. And therefore, a lot of data collection with each individual, but one important part of the engagement was what we call a go-along interview. So we walked with the individuals living with dementia in the neighborhood, asking questions about the environment that they navigate and what challenges they faced and so on. So what Mohammed is presenting here is more objective data of the walk-along interview. So for example, how long did people walk as we walked with them? How far did they go from their home? How long did they take? And more importantly, what are the environmental contexts of their walking landscape? And that data was collected through GIS data, or Geographic Information System databases, that we collected from different municipalities, TransLink, and so on. So we looked at like 5 different GIS databases and looked at, for example, the benches, the sidewalks, the land use. What kind of land use? Were they more residential? Were they more commercial? mixed use, all kinds of geographic information-based data that really helped us contextualize how people were making the decisions in their walking behavior. So that's the context. I think you may want to keep that in mind as you watch this. All right, here we go.
Hello, everyone. I am Mohammed Jawad Nouri, Alzheimer's Society of British Columbia postdoctoral fellow. I am working with Professor Habib Chaudhuri in the Department of Gerontology at Simon Fraser University. Today, I want to talk about our research in the Demescape project, which is mainly about the effects of neighborhood environments on walking activity of people living with dementia. The focus of this study is mainly on people who lives in Metro Vancouver region. So before I want to talk about our research and findings, I want to talk about why a spatial analysis is needed in this field of study. We reviewed the literature. We noticed that there are three main stream of scholars that working on this topic. The first group focused on social aspect of neighborhood environment that can affect walking activity of people living with dementia in their communities. The second group focused on built environment factors, and the third category of a scholar focused on life space of people living with dementia in their communities, which their focus is on GPS technology and everyday technology. There are other scholars that synthesize the social and built environment factors, which in literature we call them relational approach. When we reviewed the study, we noticed that social and built environment research mainly use a qualitative analysis, and the life space measurement group of scholars focused on quantitative studies. We believe that the spatial approach to this kind of research can bring both qualitative and quantitative studies together and analyze different aspects of walking activity of people living with dementia, including social and built environment and also life space. And also we believe that by applying a spatial approach in this kind of studies, we can influence community design and planning plans by identifying intervention spot in communities to improve the neighborhood environment for people living with dementia. So in the Demescape project, our focus to apply a spatial analysis can be categorized in two main categories. One is quantitative analysis, in which we work on descriptive analysis, correlation analysis, and regression analysis, and also qualitative analysis, which we focus on thematic maps, sentiment analysis, and video analysis. In this presentation, I'm present just descriptive analysis of a spatial analysis that we have conducted on our participants and their communities. So in this research, we focused on three main questions. What are the characteristics of the walking journey of people living with dementia during their regular walking activities in their neighborhoods? What are the characteristics of the neighborhood environment of the walking routes that people living with dementia choose for their regular walking? And also, what are the characteristics of the 20 minutes watershed area surrounding people living with dementia home location? To answer those questions, we articulate a conceptual framework and choose variables and databases. So our conceptual framework is mainly based on three parts. The first one is demographic characteristics of participants, which we use questionnaire to gather data related to that: age, gender, ethnicity, education, are some examples of those variables. Walking journey characteristics is mainly about the home location of the participants, the walking route that they choose to walk regularly, and also the regular destination that they use to walk. So to capture data related to this kind of characteristic, we use GPS data, which has been captured by research assistant during walking interviews in the communities. Also, we gather data related to neighborhood characteristics, including land use, street network, supportive street furniture, public transportation, socioeconomic status, by using several databases, including Metro Vancouver land use, TransLink transportation dataset, the census data, and also field observations that conducted by our research assistants in this project. So this research is based on the spatial analysis of walking activity of 25 people living with dementia who reside in Metro Vancouver region. You can see the spatial distribution of them in the left picture. And in the right picture, you can see the spatial scale of analysis. For analyzing the walking activity of people living with dementia, in contrast with what we have in the literature on this topic, we choose two different scales. The first one that you can see with blue arrow in the right picture is the walking route that the participant chose to walk to their regular destination. And also you can see the walkshed area here that can show 20 minutes walkshed with different cutoff range. For example, the dark green is 0 to 5 minutes, the light green is 5 to 10, and orange is 10 to 50 minutes, and the red one is 50 to 20 minutes. So we analyze all the data we had for walking shed area and also neighborhood environment characteristics in this 20-minute walk shed. So let's see what were the results. The result for journey characteristic shows that participants walked an average of 1 kilometer from home to their destination. And also almost half of the participants walked less than 1 kilometer to their regular destination, while the other half walked between 1 to 2 kilometers. And about the round trip walking activity, which means the distance from home to regular destinations of participants and the return path from the destination to their home, shows that an average round trip distance is 1900 meters. With the range between the minimum was 470 and the maximum was more than 4 kilometers. The other journey characteristics variables are related to the time. Our analysis shows that participants reported an average round trip walking time of 33 minutes, which the minimum was 10 minutes and the maximum was 1 hour. Also, our worksheet analysis showed that 80% of the participants walked to destination within 50 minutes time ring by considering 4.8 kilometer per hour as their speed, while 20% walked for 50 to 20 minutes. The next variable is land use pattern. We analyze different type of land uses along with the walking route and also in 20 minutes walk shed. The results show that the focus, the main land use that surround the walking route are residential, retail and other commercial buildings, and also recreational open space and natural areas. In 20 minutes walk shed, we can see that there are mainly residential and recreational land uses. By comparing these two, we will notice that our participants try to use walking routes that include more recreational open space and natural areas, and also retail and other commercial in their communities. Here is an example of map. You can see here the walking route that participant walk through. This is the regular walking route. This is the land use pattern that you can see. You can see that in 20 minutes walk shed, most of the parcel has residential land use, and participants chose to walk to a mix of land uses here, which show us that exactly our results suggest people living with dementia may choose walking routes based on a specific land use pattern that differ from those found through the broader watershed area. Here is another example. You can see most of the parcel here has residential land use, but participants try to choose walking route where most of the parcel has green space land use or health and educational land uses. But for example, for these participants, they choose to go through a walking route that's surrounded by residential, just residential land uses, which shows that there is a need for more deeper studies in more deeper studies on the relationship between land uses and walking route that people living with dementia choose for walking. Here we can see a mixed land use pattern. We constructed entropy index to analyze the mixed land use and how much our participants are encountered with the environment with mixed land use pattern. So the results show that most participants choose routes with less exposure to mixed land use than the surrounding watershed, but 32% of participants opt for routes with a higher entropy index. This conflict in results shows that there is a need for deeper study on the relationship between land use pattern and walking route that participants choose to walk. We also analyze the blue spaces and green spaces in communities and the proximity of participants to this kind of land use. Our results shows that 70% of participants select walking routes that include adjacent public green spaces. The other variable is public transportation. Our results show that most of the participants only access to bus stops and bus routes as the main mode of public transportation. Totally, our results show that the residents, the participants choose walking routes that have good access to bus stops and bus routes. Here you can see a map that shows the participant home. The red line is the walking route, and you can see how many bus stops are near the walking route. However, in the right map, you can see another participants that their home location cannot provide them with a good access to bus stops and walking routes. So we believe that there is a need to more deeper studies on the relationship between bus stops, bus routes, and different kind of transportation mode in this field of study, and how this kind of public transportation can affect walkability, outdoor walking experience of people living with dementia. The other variable is street network. We focused on level of function of the streets. The result shows that participants choose residential or local roads for walking, which can provide them more safe environments. But there are some participants, as you can see here in the map, that they choose secondary streets that is a higher level of function in comparison with residential, but they can provide them with good infrastructure of sidewalks, good access to different type of land uses like green spaces and health and educational, and also open spaces and community center. So there might be some factors that affect the preference of participants to choose walking routes according to level of function of the streets that needs more deeper studies. Here you can see the slope percentage that can really affect the experience of people living with dementia in walking activity. Selected walking routes of participants had an average slope of approximately 2.8 percentage. You can see that there are different route that participants chose to walk according to a slope variable from 1.4 as minimum and 6.1 as the maximum. Here you can see a video that show that how participants here. How participants experience a slope when walking through the walking route they choose. You can see they must pass this kind of elevation profile to arrive to their destination and coming back to their home. The other variable is sidewalk and supportive furniture. On average, 95% of the length of the selected walking route is occupied with sidewalks. Averagely, there are lots of benches in walking routes that participants choose for walking. Only three participants had access to washroom along their walking routes, which shows that street infrastructure in this kind of furniture is not sufficient to support their walking experience. And nearly 70% of participants had no access to any shelters while walking. The other variable is street network, which we focused on presence of intersections. An average of 5 four-way intersections on walking routes must be passed by participants when walking in their chosen walking routes. 8 participants encountered only 1 or no four-way or more intersections, while 4 participants encounter more than 10 four-way or more intersections while walking. Intersections are really important because those are the points that participants must decide to change direction or not. So more intersection in the walking route can be confusing for them. Thank you for your attention to my presentation. Enjoy the seminar. Bye.
For John and Jennifer. So, yeah. I think I'll start off with one question for John. My question is about the association between cognitive health and physical activity. And if I missed that, forgive me, but I'm just thinking about the other relationship, physical activity affecting cognitive health. So somebody, in terms of, let's say, functional decline and affecting lack of ability for physical activity, staying active, and how that might affect cognitive health.
Yeah, it's a great question. I mean, I think there's a lot of interconnections and interplay amongst these things, and so it can be kind of hard to determine what causes what. So if I understood one mechanism, you could have some functional decline, impairment leading to a lack of physical activity, and in turn, perhaps cognitive decline, something like that. Yeah, so that certainly could be it. So it's not volitional, really. It's physical impairments. That certainly could be happening in our analyses. I suppose we kind of avoid that by adjusting for, in a very crude way, the number of comorbidities. But I think that could be something that's happening. I mean, it could also, there's also the question about, and this is really why interventions are required to determine what's going on, but you could have a kind of a generic degeneration that affects physical systems and muscle mass and balance, and then so that would in turn lead to a decline in physical activity, and then later on you see it in neurodegeneration. So there could be some things like that are leading to a sequence of decline in that way. I think so. None of these have been ruled out and just foot stomped. Interventions are the kind of the gold standard for kind of determining what might be a causal effect, and in turn would be worthy of intervention and that sort of thing.
Hi, Jennifer. I wonder if you can speak at all to the impact of our decrease in GPs in society and its impact on multimorbidity. Just curious.
Yeah, thank you. That's a really great question, and I think it's a really, really important one, especially for today's healthcare system, because of course we know that access to GPs is declining, is a major barrier for a lot of individuals in BC and across Canada. So for sure, I think GPs and other general practitioners of any kind, including gerontologists as well in this category, are really important with multimorbidity because they give that generalist perspective and they can help to do some of that coordination and integration of care. So I think addressing the shortage of GPs is one way, an easy way without having to do any major overhaul of the healthcare system, that we could try to improve access and ease of access for individuals with multimorbidity.
And just to segue with respect to the healthcare system, which we know is in crisis, we can't listen to any news these days without hearing about it. But Jen, just to maybe push a little further, I'm wondering if you can elaborate on how your research might address some of the healthcare problems, and specifically how perhaps making it more efficient and effective.
Yeah, absolutely. That's it's a big question. It's an excellent question. I will say, to not overstep any claims that I could make about my research, we're really looking to characterize multimorbidity, and it's really at the disease surveillance level. However, I think the knowledge that's generated from that will provide the important motivation to make the policy shifts to actually improving healthcare. And so one way that it could do this is if you do have a better understanding of the intersections and the overlaps between different conditions, it could help identify specific avenues where care needs to be streamlined. So if you know that individuals with a certain cluster of diseases are at a very high risk of accumulating a different disease that would normally go to a separate specialist, then that's something that you can start to predict for and plan for in your strategy of care. But it also could just help with general resource allocation and understanding where we need to be putting the money in the system so that you can have that most efficient delivery of care.
Jennifer, I noticed on your chart there of all the different diseases, et cetera, that you didn't have influenza and pneumonia, which have comorbidities for sure. So can you speak to that, please?
Yeah, absolutely. So those are infectious diseases, and they're not covered in the chronic disease surveillance system. So those are tracked certainly at the provincial level, but it's separate databases. But it's a really important point, and multimorbidity, similar to many other areas of healthcare research, there's an underrepresentation of work in lower middle income countries, and those are areas where infectious diseases like HIV or hepatitis C can certainly have very long-term chronic impacts. So to your point, around infectious disease and its intersection with multimorbidity, it's very important, and I think we're just starting with the diseases that are available in the chronic disease registry. Those are available because of their prevalence and because of their importance from that chronic disease perspective, but the chronic versus infectious disease distinction it's not always useful, and we know that it's limited. So I hope eventually that will move towards a more broad perspective with this work.
Any last question? Last chance? If not, then I'd like to thank Jennifer, John, and Mohammed for so much for a wonderful session. Thank you very much. All right, so time for a break. We will come back and reconvene at 3:30 sharp with our last session on elder abuse from a diversity lens. See you in 15 minutes.